nothing called saphennomaxillary suture. There is only saphennomaxillary fissure, which is the most important fissure in the whole skull. It is the door between two rooms. Laterally, the intratemporal fossa, and medially, the sphenopalatine fossa. Laterally, intratemporal fossa, then the fissure. Sphenomaxillary will take us to another fossa, sphenopalatine. Then from sphenopalatine fossa, I'll go to a cavity called nasal cavity through an opening called sphenopalatine opening, or sphenopalatine foramen. The artery that went through the infratemporal fossa called maxillary. And when it enters through the door between sphenopalatine and infratemporal, it becomes sphenopalatine. Then when it goes into the nasal cavity, it is still sphenopalatine, but it splits into two in the roof of the nasal cavity. Branch to the septum, septal branch, and branch to the side wall, called lateral. The branch on the septal or the septum are going anteriorly to join, coming from the internal carotid, something called anterior ethmoidal, to form something called Kieselbach plexus. We didn't continue with this because of the glitch last lecture. And in Kieselbach plexus, I have plenty of other arteries also contributing to it. For instance, the septal branch from the facial nerve, which is coming from external carotid or internal carotid? External carotid. And also, through the incisive fossa, we know that if the hard palate, okay. If this is the hard palate, okay. If this is the hard palate, there is greater palatine running laterally, arching with the palate, and when it comes to the midline anteriorly, or near the midline anteriorly, it will go up through incisive foramen to run in the septum, contributing also to Kieselbach plexus. What an arrangement. So I mentioned 4 arteries contributing to Kieselbach plexus. These arteries are sphenopalatine, anterior ethmoidal from internal carotid, and septal branch from facial, coming originally from external carotid, and greater palatine coming from external carotid. By the way, greater palatine is a branch of maxillary or sphenopalatine? Sphenopalatine. While sphenopalatine artery is in the sphenopalatine foramen. This is Kieselbach. And when I have intractable bleeding, meaning that when I need to control bleeding which is not responding, I have either to embolize the artery responsible or to go through the bones in a destructive way to ligate the artery responsible. One of the ways is to open here and to go to the ethmoid, like this, eventrate the ethmoid cells and go to the anterior ethmoidal, but it is effective, and then ligate it. But if the bleeding is posterior, most probably it is coming from sphenopalatine. Here I will enter through the nose. And when I enter through the nose, I go posterior, posterior, posterior until I have certain landmark which is telling me here is sphenopalatine foramen, and I will dig into the bone and I will control the bleeding. Anyway, I hope it's not too late to say it, but we start now. As I said, saphenase is sphenoid. Today, I'm calling saphenase another name. I'm calling saphenase a name you know very well as well. I'm calling it pterygoid. Why am I calling it pterygoid today? As you can see, it looks like that this is the head of a cat, and these are the wings and the legs. This is pterygoid. And you can see nicely how from posterior view, this is here foramen. Foramen? Which foramen? Rotundum, excellent. Excellent, wallahi. And through rotundum, which is inside the cranial cavity, will have V2 entering into sphenopalatine free. Yes. Thank you. And through rotundum, this is why I don't speak, because it is Ariba. Okay. I speak and you speak. Okay. ماشي. Okay. See. بدور عن مية لأن عطشان. Okay. So, shall I start from the beginning? Okay. So, sphenoid is called pterygoid, and this is posterior view, this is anterior view, and you can see foramen rotundum, as you said. V2 is entering from here into sphenopalatine fossa, carrying systemic contribution, pain, temperature, feeling, whatever, that will go to the nasal cavity. And the foramen which is carried autonomic will be this and this. Autonomic at this, and this is just outside the cranial cavity. Just outside the cranial cavity. This opening is opening for pterygoid nerve. The pterygoid nerve is formed of two petrosals. The two petrosals, أنا أتكلم يعني. The two petrosals, معلش, bear with me. قربوا عليا. The two petrosals. Battery? Okay. Thank you. The two petrosals, superficial and deep petrosal. And they are the autonomic contribution to the sphenopalatine. So I have a nerve passing through rotundum, and the other are passing through the root of the leg. So the root of the leg, at the root of the leg, autonomic. At the rotundum, I have systemic. Root and rotundum. Both of them are R. But there is funny thing here. Can you see this funny thing? What do we call this funny thing? What do we call it? At the root of the medial plate, I have an opening. This opening is for the autonomic contribution to the sphenopalatine ganglion in the sphenopalatine fossa. This sphenopalatine ganglion will give me the autonomic for the nose. There will be a nerve going to the nose, big nerve, especially to the septum, called, I remember it by Napoleon, called nasopalatine. I call it Napoleon nerve. Nasopalatine. Going mainly to the septum and giving to the side wall Napoleon is there, nasopalatine. What's the name of the artery? Sphenopalatine, which is the counterpart of it.
These are for only the medial septum.
Nasopalatine, nasopalatine for the septum and the lateral and the side wall, the upper part of the side, or the whole side wall of your arm. Okay? The artery the same. That's the same. Sphenopalatine for the septum and the side wall posteriorly, but anteriorly.
Okay.
This is anterior ethmoid. This is anteriorly. This is the area of anterior ethmoid, because as I said, tip of the nose is 1, and this is V1. The nerves are 2. This is V2. V2 sphenopalatine artery. V2 nasopalatine nerve. Did we get that? Good. So this opening here at the root of the medial plate. So the medial plate is important. And this is what? Called what? Huh? This is called what? Say it again. Hamulus. Excellent. What's hamulus? Isn't this a bird? Isn't this a bird? And the bird should have a claw. It's similar to a claw of a bird. مش ده bird? Pterygoid? Madame Safi? Hamulus. This hamulus, we'll play with it today nicely. Really nicely. The hamulus. Can you feel it? Can you see it? Yes. If I go with the tip of my tongue posteriorly, I'm feeling the hamulus here and the hamulus there. Can you feel it? Yes. Don't say no. Okay, we can go with the tip of the tongue to the soft palate. في الآخر, you can feel it. Okay? So you feel the hamulus here. Can you feel it with your finger? Yes. But don't break it. It can break. Okay? Don't take your small brother or sister, the hamulus. Okay? No. Very good. You feel the hamulus with your tongue? Yes, everybody can feel it. Right? Very good. So, this hamulus is going to be connected to this area behind the crown of the last mole. Hamulus, I call it Napoleon? No, it is near to Hamlet. Hamulus, Hamlet, you know Hamlet? If you don't know Hamlet, it's okay. Hamlet was a king, and this is the crown of the last mole, or crown and the king. From the hamulus, I have a ligament called pterygomandibular ligament, for short PMR. PMR. For short, PMR. Pterygomandibular ligament. Standing from the hamulus of the pterygoid, and the hamulus is the lower end of the medial plate of the pterygoid process of the leg of the bird, and it is going backwards in the space between the ramus of the mandible and the crown, the last molar. Pterygopalatine ligament. The pterygopalatine ligament is very important. Pterygopalatine raphe, PMR. Are you following? Oh, pterygomandibular, I beg your pardon. I said palatine, I beg your pardon. Thank you for correction. Pterygomandibular raphe, PMR. Pterygomandibular raphe. الناس اللي ما سمعتش عشان ما فيش ميكروفون. Okay? So PMR is pterygomandibular raphe. Here is another view. What's in here? What do you call this? Posterior nasal aperture. لها اسم starting by C and H. مش concha. Kuana. What's it called? Kuana. And the plural? Kuani. Kuani. What's the other thing which is at the side of the nasal cavity? Concha. Concha. And the plural of concha? Believe it or not, according to the Latin, the plural of concha is concha. Thank you. الله ينور عليك والله. الله يسلمك. الله يخليك. So, from the hamulus to the mandible, I have femur, pterygo mandibular raphe. This is pterygomandibular raphe. In the area of the neck, okay. Okay, a big hand for it. So, pterygomandibular raphe is between the hamulus and the mandible, in the area between ramus and the molar, the last molar. And as you can see, it is attached anteriorly, or attached anteriorly is a muscle which is forming the lateral wall of what we're studying today, the vestibule of the mouth. This is the muscle of the cheek, buccinate. And posteriorly attached to it is the muscle of the pharynx. Muscle of the pharynx is posterior, called SCM, superior constrictor muscle of the pharynx, SCM. While the muscle here is called buccinator. Buccinator is the floor of a fossa in the face. But it is the side wall or the lateral wall of the vestibule. في هنا, there is here a fossa full of fat, which is just, the fat is there to be level with masseter, to give me the roundness of the face. If I remove this fat from over buccinator, I will look like the mummy. Are you following? Good. And as you can see, there is, this is not decoration. This is parotid duct, piercing. And so this is pterygomandibular raphe, and because the area here is crowded, I find more than two muscles even sharing the same structure for origin. It is as if we have a crowded city where more than one family are occupying the same flat. Pterygomandibular raphe, buccinator, SCM, superior constrictor muscle of. We notice that the superior constrictor muscle of the pharynx doesn't go up to the base of the skull. There is a gap in the wall of the pharynx. Why doesn't the constrictor muscle, why doesn't it go up to continue the tube of the pharynx? Why? Because I have nasopharynx at this level. Okay, excellent. Why doesn't it go up to the nasopharynx? Why? I did tube. This is the tube. Are you following?
Yeah.
Why the constrictor is staying shy away from the base of this? Why doesn't it go up? Why doesn't it go up all the way to continue the wall? Here the wall is continued by a membrane. Why doesn't it go up?
Because we need the muscle for breathing.
You are near because
Swallow.
so because
Swallow.
we don't swallow up. Do I eat food from my nose? I eat at the level of the mouth here. Is the mouth level with the base of the skull? This is why the constrictor will go down, shy a bit from the upper part of. Are you following? Very good. So here is superior constrictor, and this is its upper edge, not going all the way up, because I don't eat at this level. This is why the wall is deficient in muscles. But instead of muscles, I have strong membrane called pharyngobasilar membrane. We'll see this in a minute. Now you know what's needed. Here is which part of the oral cavity? Vestibule. And this is the oral cavity proper. This muscle is what? Vestibule. You are right. In the vestibule, I have a very important structure. You can look at the mirror and do this, you'll find it. What I'm going to look at. Parotid gland, which duct? Opening. And it makes a papilla. It makes a papilla. You can look at your selfie and you will see it. This is me. Yeah, you can see my beard. And you can see my dirty teeth. Okay. And then لا انا كنت لسه شارب حاجه فيها عسل وبعدين وطحينه كمان وبعدين and this is here my papilla. Can you see the papilla? Can you see?
Yes.
Can you see here this? Yeah. This is the pterygomandibular raphe. And here, when my tongue goes back to feel hamulus. Look at this. I have a good selfie, by the way. Wallah, very good camera. And they told me, careful, don't lose this computer because it has very good camera. And this is pterygomandibular raphe. This is the hamulus. But this is not the raphe anymore because it is covered with mucosa. It is called pterygomandibular fold. Fold. It is called fold. So this is here parotid duct, axillary. This is pterygomandibular fold. So this is pterygomandibular fold. And now he called it raphe because I got it from the internet, and the internet, as I said, always wrong. It is fault. And here, the dentist is going to inject lateral or medial to the fault. Lateral. And how many times? They use in McGill because I used to teach the dentists as well. Here it comes. There is a patient in the clinic who is numb. His whole face is numb and not moving anything. He cannot close his eye, and this is drooling because the entrance was very lateral and it reached the fascia nerve. Do we go medially here? If you go medially here, you might go to the internal carotid, which is worse. Are you following? But when we go lateral here, we go to the infratemporal fossa, where we find the inferior alveolar to numb this area for work, to numb the lower and the floor of the mouth. And here we have the papilla and vestibule. Vestibule, by the way, this is vestibule of the nose. This is vestibule of the mouth. Between the teeth and the alveolar process and the gum in one hand, and the cheek in the other, and the lips anteriorly in the other hand. And there is vestibule of the larynx. So the word vestibule, they gave it to me because they know that I like this area and I teach this area nicely. The only thing I know in anatomy, perhaps. So they gave me this, just small-minded, so here is vestibule, vestibule, vestibule. Now, if I ask a question here, what's the nerve supply of the vestibule? Two nerves. Because the vestibule is containing the tip and the nerves. So, ophthalmic is the tip because I have one tip. V1 for one tip. Tip 1 for V1. V1 for tip 1. V2 for two nerves. So the vestibule is supplied by two nerves.
Of the nose.
That's of course of the nose. Speak about the nose, tip and nerves. Are we following? Very good. How about the vestibule of the mouth? The vestibule of the mouth, somebody called maxillary above, mandibular below. Are we following? The vestibule of the mouth, maxillary above, mandibular below. Of trigeminal, of course. How about the vestibule here of the larynx? Vagus. And if I name it, it is internal laryngeal nerve. Then I have here respiratory part, and then I have olfactory. You remember the olfactory area? What supplies temperature feeling and pain feeling in the olfactory area? olfactory برضه nerve هو اللي هيسبلاي the pain with temperature. Trigeminal. Which part of trigeminal? Which part? لما الupper part of the vestibule V2 هيبقى ده ايه؟ V2. Are you following? Good. Maxillary. Then I have here something that we'll discuss nicely, which is called the pharynx. This is very beautiful thing that will remind us what we are going to study today, so I will not forget. In this patella, وطبعا كان عندكم you had an exam, you had an X-ray exam. Is this X-ray or is it CT scan or MRI? CT. Certain This is CT of the face, and it is coronal, and I can see that. Why is this large? Because there is a stone here, and you see the duct how it is dilated. When I come to the floor of the mouth, which is supplied by V2 or V4, V3, V2 or V3, mandibular. When I go to the floor of the mouth, it is occupied mainly by the tongue. Mainly by the tongue. And under the tongue, there is a very nice space called submandibular space. The submandibular space is occupied by a very well-known fold. The fold is called sublingual fold. And the sublingual fold, the sublingual fold is going like this, and like this, like an arm of a chair. And the sublingual gland is underneath the arm and sending a line of ducts to open at the edge of the fold. Are you following? يعني كده وكده والgland, the gland is underneath the fold and sending 11 or 12 ducts opening at the edge. Are you following?
Yes.
And submandibular is backward, but sending its duct medial to this armchair, but going at the very anterior of the armchair at the midline to open at the caruncle. So, this is the armchair. Armchair. We call it in Arabic دي بقى اللي هو ايد الكنبة. زي ما تقولي armchair يعني ايد الكنبة. Okay, Ayman? Okay. So, ادي الكنبة كنبة. اللي عند الكنبة وادي طلع منها اللي هو the duct, which is opening at here. This is دي ايد الكنبة اهي. وبعدين الكرانكل هنا في الحتة دي. This caruncle is for the opening of the duct, which is running immediately near the canal. Following or not?
Yes.
I hope. And here is the frenulum. Frenulum of what? The tongue. Sometimes the frenulum of the tongue is short. And this is what we get. Ankylosing. This is neglected ankylosing. كبر أو في أسنان. There are teeth. يعني مش صغير لسه. It's not okay. But the effect here is it gives a bad latch. You know the latch?
Yeah.
The latch is a term for the first encounter of breastfeeding in our life. We call it, oh, he had a good latch, this baby with his mother. Oh, he had a bad latch because he's premature and weak. He has a tight tongue or whatever disease he has. And this, if we neglect it, if you compare, this baby will have high arched palate compared to this. And it doesn't matter, but what matters is the mother will come with nipple cracks because here the tongue is not going nicely as it was or as it should be. So this is something that we have to remember about the tight tongue. Now, you had an exam, an X-ray exam, so? Okay, what are these? What do I call these? X-rays, very good. Call them something. Cyanogram. What is that called? Cyanogram. And if I have stone, I will call it cyalolithiasis. Cyalolithiasis. This cyanogram, can somebody tell me which one belongs to the parotid? Which one I can say this is parotid cyanogram? Go ahead.
The top one.
لا the bottom.
فين؟ في منهم واحد.
bottom.
Three of them are cyanogram of submandibular and one of parotid. What is the one for parotid? The right, exactly, this one. Because here I am near the second molar, here I am near the upper jaw. So here, this is the cyanogram of parotid, the rest are for submandibular.
Okay, so it's a view.
Here is submandibular duct, aiming at the caruncle, and this is lingual nerve. And in my notes in 2009, why I'm remembering, because these are the notes which were accepted by McGill as the resource and the reference for anything in the head and neck. قفلوا كل الكتب وفتحوا النوتس بتاعت الجدع ده. وقالوا هو ده اللي نمشي عليه. كل الكتب فين؟ الحمد لله ما شاء الله لا قوة إلا بالله. قلت أنا بقى في النوتس دي بقى إيه؟ قلت there is a relation of between the lingual and the duct. إيه الريليشن دي سميتها إيه؟ The guitar handle. Why the guitar? Because if I am catching a guitar handle, I'm going to do double cross. And this is the double cross. مين بقى الهاندل بتاع الجيتار ومين الهاندل بتاع البلاير؟ The handle of the guitar is The duct, excellent, wallahi, excellent. And the player is the lingual. Ah, okay. Now, please, لا معلش مش حاول. At the floor, حاول. This is here, the lingual now. This is here the guitar. And this is here my hand going like this to play. Are you following? شفتوها? Okay. Now, if I go here at the floor, the main muscle forming the floor of mylohyoid. And mylohyoid is arising from here. There is a bone. This bone is at the meeting of the floor of the mouth and the upper part of the anterior of the neck, hyoid. This hyoid has got a body, and from its name, it got two horns, lesser and greater horn. This muscle is arising from where? From the body or from the horns? From the body. Now hyoid is like this. Are you following? Greater and the body here. This muscle is arising from the body and going anteriorly and spreading like a fan. Going to the mylohyoid line. The opposite of it is a muscle. In the notes of 2009 McGill, I wrote that this muscle, hyoglossus, is more or less its opposite, but this muscle, I called it the central structure of this area of the head and neck. Why? I explained it in my notes. So, but this muscle, hyoglossus, I should not confuse it with mylohyoid. This muscle, hyoglossus, today, the only thing that I will convey to you is that it is sharing the same flat with the middle constrictor of the pharynx. Hyoglossus is lateral and the middle constrictor is medial. So first we spoke about a constrictor called superior.
Yes.
And this superior constrictor shared with buccinator femur.
Yes.
And then middle constrictor of the pharynx is the second muscle we spoke about. And it is sharing origin with hyoglossus at the greater horn of hyoid. Please do not confuse hyoglossus with mylohyoid. دي هتروح رايحة كده ودي هنا هتطلع كده للتانج. Now, this is what? Hyoglossus or mylohyoid? Hyoglossus. Here is mylohyoid. And above mylohyoid, geniohyoid. And then genioglossus.
Doctor, can you show us the middle constrictor in this one?
Can I show you the middle constrictor? It is here. Why? Good question. Because it gives me chance to brag as well. Because this is middle constrictor, this is superior constrictor, and this is here hyoglossus, and I call this triangle the second gap in my notes. I call it because this is the first. بس مش هنقول الجاب والكلام ده لأن النوتس اللي هناك جهازي، إنما هنا أنا خفيف النهارده. I call this the second gap through which this and this structure is passing. Very good. Very good. We are doing well so far. Here we are. If I ask somebody, open your mouth, now we understand. What is this person going to feel here? Hamulus. And from hamulus, we have what? PMR, which is now PMF, pterygomandibular fold. And this here will be the uvula. and this is the soft palate. And from the soft palate, I have a fold, another fold, fold number 2, and fold number 3. Between fold number 2 and 3, I find tonsils. These tonsils, we call them palatine tonsils. Fold number 1, its upper attachment is what? Annulus. What's the lower attachment? Bone. Bone. Mandible. Bone. Area of bone between last molar and the ramus itself. Second fold. What's it called? What's it called? Second fold. What's the name of the second fold? شايفين اهو. First, second, third. What's the name of the second fold? Palatoglossal fold. What's the name of the third fold? Palatopharyngeal fold. What's the upper attachment of the folds? Palate, soft palate. Both of them. What's the lower attachment of the folds? 2. 2 to the tongue. And palatopharyngeal to what? To the pharynx? No. أدفع ريال. لا. The upper attachment is? The upper attachment is? Soft palate. The lower attachment is?
The thyroid?
Thyroid cartilage. So, there is here, inside here, there is a muscle called the palatoglossus, covered by mucosa, and I call this palatoglossal fold. There is a muscle here called palatopharyngeus, covered by mucosa, and I call it palatopharyngeal fold. And what's the attachment?
The thyroid cartilage.
Thyroid cartilage. And by the way, this muscle, which is going like this, is it vertical or horizontal? Vertical. There are 3 verticals ending by pharyngeus. This is one of them, called paratopharyngeus. And the other vertical is salpingopharyngeus. And the third is stylopharyngeus. The 3 of them, stylopharyngeus, salpingopharyngeus, palatopharyngeus, are attached to thyroid cartilage. What do they do when I swallow? They pull up the thyroid. So they pull up the larynx. Which one is the strongest? Is it stylo or salpingo or palato? ستايلو ستايلو because عشان يا سلام والله انت لا حدولي خلاص سيدي والله العظيم فرج على نفسك يا شيخ يا شيخ الله اكبر اصرفي بعزائي يا شيخ الله Are you following? جيب كوبايه شاي صغيره كده بريال اوكي Are you following? Good. Stylopharyngeus. Stylo, very strong, and it elevates the thyroid cartilage belongs to the larynx. This is why I call stylopharyngeus in my notes levator laryngeae. شايفين الاسم levator laryngeae. Okay, did we get that? You following?
Yes.
There you go. With our tongue, we can feel the hamulus at the back of the palate. This is number 1, 2, 3 folds in the mouth cavity. This is called pterygomandibular fold, and this is palatoglossal, and this is palatopharyngeal fold. Between 2 and 3, I have palatine tonsil. Number 2 ends the voluntary stage of swallowing. And past number 2, behind number 2, the second stage of swallowing starts, where all the reflex starts and it is involuntary. Here, if I am eating and the food is reaching here, I can spit it back. But when it goes after that, I cannot spit it back. So second stage and second fold. Second stage and second fold. We don't forget. Here is a dissected oral cavity proper. What's the name of this? Which I can feel here. Annulus. What's the name of this? Hemar. Pterygomandibular rasp. What's the name of this? What's the name of this?
The style
Superior constrictor. What's the name of this?
the ethmoidal artery. This is the cartilage.
Bone, the palate, sometimes bone.
Soft, Allahu Akbar. Soft palate apneurosis. مين اللي قالها دي؟ مين؟ Where? Raise your hand, please. Soft palate apneurosis. ما شاء الله. Soft palate apneurosis. What's the soft palate? The soft palate، اسمعوا الحتة دي ما حدش هيقولها غيري. أنا هغنيها يعني I will make it like a song. Nobody will go to this because I like it. I dissected over 1,300 cadavers. This is why McGill accepted the notes at the reference. مش accepted ده عينيه سودا لا. لا. They accepted it because he worked hard. He proved that he is always right, and he read more than anybody. So, when we speak about the soft palate, how can I describe it? I describe the soft palate, the quadrangular membrane هيساعدني هنا. You remember we had very good. You remember we had this. You remember this? The soft palate is nothing but a muscle which is coming from here like this and making 90 degrees. And from the other side making 90 degrees, and they are meeting. How many muscles in the body that makes 90 degrees? حطيتها برضو في النوتس بتاعت 2009. How many muscles? One in the body. How many muscles making 90 degrees in the body? عشان تعرفوا في فرق ما بين اللي بيدرس اناتومي بزبالة كده واللي بيدرسها بتمعن. أنا مش عندي زبالة خالص. لا يمكن. There are 6 muscles in the body that make 90 degrees. One of them is this. هديكوا واحدة تانية. Obturator interns. أديكوا تالتة مش هديكوا. خلاص؟ يبقى دي مين بقى؟ المصل دي اسمها ايه اللي بتعمل 90 degrees and it goes around the annulus, which you are going to play with. The muscle is called tensor palatine. What's it called? And this muscle, when it makes the 90 degrees, شايفين تعمل 90 degrees and it will spread like an apneurosis. 2 apneuroses like this, they are meeting in the middle. To make, that's bad, to make the core of the soft palate. To make the core of the soft palate. You agree? To make the core of soft palate. And there are two muscles diving into it. جايين من فوق زي الصواريخ كده, like a rocket, diving into it. These two muscles are called levator palatine. And also they spread. So I have spread 1 and spread 2. These two spread, like I'm making a sandwich now with a spread. These two spread are the soft palate. You see how the soft palate is beautiful? Not from books which are confusing and really, really disgusting. So this is the soft palate. And then between spread A and spread 2, I will have muscles insinuating themselves to make palatoglossus and palatopharyngeus. So I have floor number 2 and floor number 1. The floor of number 2 coming from the base of the skull to make for me the soft palate. And the floor number 1 is going to make the palatoglossus and palatopharyngeus. So now we know what's meant by at least the soft palate. Right, we go back here. So what's the name of number 4? Soft palate. Khalas. We know it now like our name. And it is, okay, very good. Do I have the palatoglossus and the palatopharyngeus which are making floor number 1? No, we remove them in the dissection. Very good. Now, what's the name of this opening? شايفين opening A. Greater palatine foramen. What's the name of this opening?
انسزر.
الله ينور عليك. والله العظيم انت تستاهلي ريال. والله انا عندي ريالات النهارده كتير. فك نفسك بقى واصرف على نفسك.
100 هلله يا جماعه.
اصرفي شبرقي نفسك يا شيخ. والله العظيم. محدش ياخد منها حاجه. Are you following? You want a real? Sleep again. We following? Very good. Through this opening, I have continuation to the septum for Kieselbach to be formed. And also from this opening, from this opening, I have something going in the opposite direction from above. In the opposite direction from above and going up. فاهمين ولا مش فاهمين? Are you following? So from here, I'm having greater palatine going up like this. Going underneath the palate and then going to the nasal septum. And from the nasal septum, I have something going in the other way and going like this. What's this? دي بقى اللي هتقولها حقيقي. لا 10 كتير يعني. 5 ريال. والله. ايش السؤال؟ Okay. You see this opening? This opening is in the palate, and the greater palatine is running at the sides of the palate near the alveolar margin, and then it will go through the incisive foramen. يعني هو ده ادي البالات اهو، ادي البالات اهو، وادي السبتم اهو، صح؟ That it ran like this and it came like this up to run on the septum. في بقى واحد العكس. It will run in the septum, reach the incisive to run here. ايه ده؟
superior
Maxillary, which is called Nasopalatine. لا لابد لا شبرق نفسك. خدي معي. خدي معي. لا ما. But listen, what's your name? Huh? While we are in the lecture, I'm going to ask another question. If you don't answer it, I take my friend. Okay. 7 ريال ولا 8 9 7 okay. Okay. It is the nasopalatine. It is what? That does the opposite. Okay. It's the nasopalatine. You give me the 7. Okay. Now, please watch with me. Here is the soft palate, and here is palatoglossus. Palatoglossal fold containing palatoglossal muscle coming from up, and this is palatopharyngeal coming from up. Between the two is tonsil, palatine tonsil, which is supplied by glossopharyngeal nerve. And here glossopharyngeal nerve for the posterior third of the tongue. Here, this here anteriorly should be oral cavity, but posterior to this will be oral pharynx. So here is the delineation between the oral cavity anteriorly and the oropharynx posterior. So the posterior third of the tongue is in the oropharynx. The anterior 2/3 in the oral cavity. Here I have what we feel by my tongue, hamulus, and this is the raphe, and this muscle, oxynator, and this muscle, superior constrictor, and this muscle, palatoglossus, and this muscle, and the palatopharyngeus is inserted into the thyroid cartilage. Here is a muscle, شايفين? Here is a muscle which will run to make 90 degrees and then make this. Tensor, palatine, and here is the muscle which is diving into it. Levator, palatine. Here is the tube, which is Eustachian tube. So Eustachian tube is present here in the nasopharynx. Because this is the palate, like this. So here is nasopharynx, here is oropharynx. Oropharynx is this area of oropharynx, or this area of oropharynx. This is oropharynx, because oropharynx is behind the palatoglossal fold or the palatoglossal muscle. So from here forwards, this is oral cavity. From here backwards, this is oropharynx. Now, this what I spoke about, and this is in the notes of 2009, and I got it from there. Why? Because it is my invention as well. This represents the tensor palatine, which is supplied by which nerve? اللي هيقولها هي هتديله شغال البنك دلوقتي. Which nerve? Maxillary. Take it like this. Tensor palatine, tensor palatine, tensor palatine, and tensor tympani. Trigeminal mandibular. Trigeminal mandibular. I know. No.
نوري هذا خلاص.
Okay. So, on contraction, I get it tense. This is the muscle diving into it, which is called levator. What's the nerve supply of levator? والله دي بقى مش هي اللي هتديها لنا لحد اليوم. What's the nerve supply of levator? Levator palatine.
Pharyngeal branch of the vagus.
انت جبتيها من الويب now.
Actually, you're buying me something like that.
Okay. يبقى النيرف سبلاي هنا فيجاس. Please. Levator is Vegas. Levator is Vegas. Tensor is trigeminal. Tensor is trigeminal. Okay, so levator is Vegas and tensor is trigeminal. Why levator, please, why levator? Because is Vegas. Please, I was in there. Why levator is Vegas? Because I use levator when I'm speaking, when I'm articulating. If I want to say M, I say M like this. To make M, the sound M, I have to do two things. To close the lips and to gush the air in the nasal cavity. And to do this, I have to elevate the palate, the soft palate, like this. Here is the whole story. Here is tensor palatine, making the 90 degrees, one of 6 muscles in the body. And it is hooking around the hamulus. The hamulus, we used it two times today to make the 90 degrees and to make PMR. And here is the muscle diving, but it is cut here, not cut there. Diving into the palate. And here, the muscles which are insinuating themselves between spread A and B to make palato pharyngeus and palatoglossus. Here is here is levator. Here is the spread of the 90 degrees. Here is the tube connected to the middle ear. Here is the drum. Here is the external ear. When I contract, this will open. Again, in 2009, I simulated the tube, the Eustachian tube I simulated it to simulate. It enters. I simulated it to trachea. Trachea has got a horseshoe cartilage closed by a membrane. The same applies to the Eustachian tube. Horseshoe closed by membrane. To the membrane attach the levator. When the levator contracts, it takes the membrane out, opening the tube. So the air will go from the nasopharynx to the middle ear to equalize pressure between the two sides of the drum. Which drum? The ear drum. I repeat myself. Here is the tube, which is assimilated to the trachea. Here is the membrane. Attached to the membrane levator, palatine. When it contracts, it will pull on the membrane, opening the tube. Air from nasopharynx will go in the tube to the middle ear to equalize the pressure on both sides of the drum. You will not, wallahi, you will not get this anywhere. And this is why follow it nicely. Follow it nicely. Say ah. Just I said to you, I use levator to speak. This is why it belongs to pharyngeal. It belongs to pharyngeal plexus, as our colleague said beautifully. Very beautiful answer. And the pharyngeal plexus is mostly vagus. And vagus, I use it in making the sound in the larynx. When I have to say ah, I have to elevate what? The soft palate. Like this guy, when he says ah, but he disgusted me. I don't know why. He said something as if, but anyway, we say it is ah. All right. Listen. If I ask somebody to say ah, I test which nerve now? Which nerve? Vagus. Vagus. I test what? Vagus. Suppose that when he is saying ah, the uvula will go up. You agree? The uvula will go. You know the uvula. Suppose the uvula went like this to the right. What's wrong with this? Which vagus is affected? Which vagus? If he goes to the right, which vagus is affected?
The right Vegas.
If he goes to the right, which vagus is affected? The left. The left. What do we call this? Asymmetry. Asymmetry in the raising of say he said thank you. But say I don't want you. Disgusting. Much with you going over the oral cavity and the overlap between the oral cavity and the pharynx. Now I'm trying to delve into the larynx and the pharynx now with very steady and very, very confident approach, because you are prepared, primed for the larynx and the pharynx, according to 2009, is a membranous muscular structure. No book will write this. My notes wrote this. Membranous muscular structure, MM structure. What does it mean, membranous muscular? Membranous muscular structure. A membranous muscular structure is a structure that comes into its framework or skeleton a strong fibrous membrane. I call it fascia. And on top of this fascia, hanging to this fascia, muscles. The larynx is a membranous muscular structure. It has 3 membranes and muscles attached to it, to the membrane. The pharynx is a membranous muscular structure having a very strong fascia attached to it, muscles, 3 constrictors. In the case of the pharynx, you remember I said the superior constrictor doesn't go up until the base of the skull. Who continues up then? The membrane. And the membrane is called, for this, pharyngo-basilar fascia. Pharyngo-basilar fascia continuing the whole wall. In the case of the larynx, I have 3 membranes. 2 quadrangular membranes and 1 cricovocal membrane. And on these membranes, I have a continuum of muscles. I have a continuum of muscles. And a continuum. Continuum means a continuous stream of muscles. Many muscles, but they are merging to each other around a membrane, around quadrangular up and cricovocal down. Beautiful imagination. We study anatomy in a very unconventional way. If we just read it like 200 years ago, we are not going to like it. But we are studying it in a very interesting way, a very interesting approach. The larynx is formed of L4, 4 laminae. a lamina. This is a lamina. Is a plain piece of cartilage. This represents the epiglottis, and it is formed of a lamina and a stalk. The larynx has 4 lamina. One of them is this, and 2 laminae here for thyroid cartilage, and 1 lamina for cricoid cartilage. You know the cricoid? The cricoid looks like a ring. And when I say cricoid, it's a signet ring, not like the ring of my marriage, which is irregular all over. No, it will be broad from one side and slim from the other. The broad side is called lamina. The slim side is called ash. How many laminae in the larynx? 4. How many membranes? 3. 2 quadrangular, up, and 1 down, called cricovocal. We'll see this in a minute. 2 muscles only in the larynx. For me, what I care for, and I should tell you that what I care for in the exam is 2 muscles. What are they? One of them is a muscle controlling the tone, modifying the tone, called the cricothyroid, and the other is the only abductor of the vocal cords, and it is called posterior cricoarytenoid. I'll say it again. One of them is modifying the tone, called the cricothyroid. So both of them start by crico. But one of them is cricothyroid. Kathy, I call her Kathy for short, not Safinaz. So Kathy is for the tone, cricothyroid. And the other one is CAR, which is cricoarytenoid. CAR, C-A-A-R. CAR, cricoarytenoid. And this cricoarytenoid is posterior, and it is responsible, the only abductor of, then A2, 2 articulations, 2 arytenoids. Arytenoids are the bones, which are the central bones in the larynx. Because, why? This is for short, but we'll go in detail now, inshallah. Because, what's the function of the larynx? Protection and production. The larynx, I divide it into 2 parts. The upper part for protection or production. What's production of what? Voice. Do you think that the upper part is producing the sound, or the lower, which is near to the air? The lower. Because when I am making a sound, I have to have gush of air coming. Are you following? Gush of air coming, and the 2 cords, the vocal cords, doing like this to make the sound. So the lower part of the larynx is involved with production of voice, while the upper part is involved in protection, in coughing, sneezing, the reflex of cough to protect the air passway. Arytenoid is connected to both, to up and down. So arytenoid is very important. Now, if this is like a signet ring, what does it represent? Cricoid. I need 2 of you now. Ariba, come on. Come on. Ariba, come on. Watch with me. Please, try to watch with me here. This is cricoid, And this is posterior aspect of cricoid, making the lamina. Sitting on cricoid are the two arytenoids, which are long. Which are long. Ariba, I want you to sit here like this. Like this, okay? Please. Go ahead. Zainab, come on. I want you to sit on Ariba's hands. From here. Good. This is here arytenoid. The lower part of arytenoid Ariba is going to be connected to the part which is making sound. The upper part is Zainab, is connected to the part which is protecting. Are you following?
Yes.
Now, please, for God's sake, let's carry on. I'll give Ariba this, and I'll give her this in the other hand. Very good.
Vocal cord.
So these are vocal cords. And I'll give Zainab this. What are these? False vocal cords. So I have here this and this, both of them like this. Attached to what? Thyroid. Aya, come on. This is here thyroid. You follow? امسك دي آية كده. يبقى هنا thyroid, and these are attached to the angle of thyroid. Are you following?
Yeah.
امسك دي كده آية. Okay, خليكي زي ما انت يا زينب. And now I'll put this here. Epiglottis.
It looks so much better from here.
It looks very better from their side. Are you following?
Yes.
So you know now how we are doing. This is called what? Angle. The three of them are attached to the angle here. You follow? This is what they see here. خليك زي ما انت يا زينب. امسكي دي كده يا زينب. وانا هجيب كده. بصوا بقى. Do you see this? This, I will attach it here like that. Okay? And تعال كده شوية بقى. هي لا تعال معي. تعال كده.
The other side.
You know. And I will attach it. فين زينب هنا؟ اللي فوق. I will attach it to the false cord. Are you following? So this will be attached to the false and attached to epiglottis to form what we call quadrangular membrane. And the same quadrangular membrane from the other side. So how many quadrangular membranes do I have? Two. روحي بقى الناحية التانية وامسكي ده كده وامسكي ده كده الناحية التانية. وأنا بمسك ده كده يبقى أنا عندي two كده. Are you following? So how many quadrangular membranes? They are attached to the false or the true? False. And attached to the epiglottis. You understand? Very good. Now, we can say to Zainab, thank you. And then I'm continuing with Ariba. You go like this. And now, I'll get a membrane. And this membrane will be attached now, not to epiglottis, attached to cricoid, and going to be attached to the true, and going like a dome to make for me the cricovocal membrane.
Yeah.
Cricovocal membrane here, like this. And here quadrangular membrane. Membrane, and there is a continuum of muscles around them. Did you get that?
Yes.
This is the idea of the larynx. You will not get it anywhere. This is why, wallah, in McGill until now, they teach it the same way I say it. And when it comes for the larynx, the recording of behavior, and they watch it. Okay? Good. Thank you very much. Big hand for them. فين النضارة؟ فين النضارة؟
Buckets over there. Beside the duck.
What? It's not. Just press the keyboard.
مثلا ساعة بتبرد بعدين كمان ساعة بس لو بيكتورين هيك دقيقة في الصيف حتى يجي هلا هيك كنتينيو هاي أول 10 دقايق هي بطل لأني بدي أروح
لو انزل حيوان كل يوم مش
ماشي ما أنت بقى أنا أسمع باجي لأني هيك على الساعة 8 وبروح هيك على الساعة 8 يعني قاعدة بالساعة ما طلعت
تسمينة على قهوة.
Membrane, and this is cricoid, trachea. The larynx is sitting at the top of the trachea, starting from C3 until C6. This is cricothyroid membrane, the place for scab, for the stab cricothyrotomy when I have supra or infraglottic obstruction supra. And this is thyroid membrane. The larynx is nothing but a cone and the dome for protection and the dome for production. Here is the false vocal folds or cord, and here is the true. Here is the continuum of the muscles. Here are the membranes, the cricovocal membrane, and here is the quadrangular membrane. Here is the entrance of the larynx. The entrance of the larynx is at the anterior wall of the laryngopharynx. And these are the two arytenoids. And the two arytenoids, always I will resemble them by this, as if I'm seeing them from above. I'm seeing them from above. This is muscular process, and here is a process which is for the cord. We call it vocal process. Vocal process and muscular process. This muscular process is attached to very important two muscles. The posterior cricoarytenoid, which is the abductor, and the lateral cricoarytenoid. The movement of these two arytenoids will be like this. If they are pulled by posterior cricoarytenoid, they will do this. If they are pulled by the lateral, they will do this. Here is the thyroid, which is the shield, two laminae, and the fusion line. This is the protuberance where I call this Adam's apple, just below the notch. Here is the angle where I am attaching the stalk of the epiglottis, and I'm attaching the false and the anterior cords. Here is for epiglottis, false cords, and true cords. Here is the most important feature of the thyroid cartilage, which is called oblique line. Again, how many families are living in one flat in a very crowded city? Here I have 3 families attached to this. I have thyrohyoid muscle and sternothyroid muscle, and I have inferior constrictor attached here. Inferior constrictor of the pharynx. Which part of inferior constrictor? Thyropharyngeus, because there is a part called cricopharyngeus. Everything will be explained now. There is here a joint. This joint is between the inferior horn of thyroid and the cricoid. Through this joint, I can take this shield anteriorly like this to stretch the vocal cords to increase the tone of my voice. Here is the shield. When I take it anteriorly, I will stretch the cords. Here is mucosa. Here is the cavity of the larynx. This is the membrane, quadrangular membrane, ending up here in what I call aryepiglottic fold. The aryepiglottic folds are surrounding the entrance of the larynx. But this fold is called false vocal fold. And this is true vocal fold. This is the membrane called the cricovocal, looking like a dome. This is the continuum of muscles I spoke about. So I have mucosa, then membranes, then muscle. Mucosa, membrane, and muscle. Here is the quadrangular membrane. Here is the aryepiglottic fold. Here is the false fold. The aryepiglottic fold is the superior end of the quadrangular membrane. The false fold, or the false vocal fold, or the vestibular fold is the inferior end of the quadrangular membrane. I forgot to tell you that we divide the cavity of the larynx into two, superiorly and inferiorly. This is supraglottic and this is infraglottic. The supraglottic space is divided into vestibule and ventricle. Now let's build together the larynx. In Canada, they like this very much. This is why I got it as such from the archives. This is here, cricoid, the base. And I'll put on cricoid, arytenoid. Then I put cricovocal membrane ending up into true vocal ligaments. Then I put epiglottis. Then I add quadrangular membrane. Then I will add
the thyroid
cartilage. Then I will add hyoid. And this will be the membrane, thyrohyoid membrane. This is how to build. Alright, for this, when I did this, I remember it was 2003. And at the same year, I got, mashallah, la quwwata illa billah. I will bring you the whole thing. The award of best teacher of anatomy in North America. Alhamdulillah. And from Boudreaux himself and Dr. Pound. Dr. Pound, he was a very influential guy. He was the president of McGill. He said, you will take this for 10 consecutive years. But, wallah, they said this, but the following year and the following year, and every year I was nominated to be the best. I said, no, we cannot do this. Always, then discard him from the table. I was discarded because every year I got it. Every year I got it. They said, discard him from the table. And I was discarded from the table. I don't care. For a minute, I care just about when you have in yourself, when you have the knowledge, alhamdulillah. Okay? Very good. So we have here this, good. Here we have the lateral cricoarytenoid. We have the site of cricothyroid stab. Can you have, this is the site of cricoarytenoid. And this is again something beautiful. This is the glottis. What's the word the glottis here? Glottis means cords and cartilage. Cords and cartilage. The cartilage is arytenoid. So it is K and K. K anteriorly cords and cartilage. Are you following? This is the glottis. Then rhemagglottis is the space between the k and the k, the cords and the cartilage. In front, the rhemagglottis will be called membranous, and here it will be called cartilaginous. So the intercartilaginous is here, and the intermembranous is here. So this is rhemagglottis. What's it called? And the whole thing is called glottis. The space plus the cord plus the cartilage, all of this is the glottis. Anything above it is supraglottic. Anything below it, infraglottic. The rhemagglottis is a space. The space between the cartilage and the space between, and it is divided into intercartilaginous posteriorly and intermembranous posteriorly, anteriorly. And now, if I'm speaking, هعملها بسرعة. If I'm speaking, the two cords are hitting each other, and the cartilage are meeting each other. Okay? If I'm speaking, they go like this, close. So when I speak, the rhemagglottis is nearly closed. When I speak rhemagglottis, the whole is closed. Are you following? When I whisper, when I whisper, it is like this. This is open like that. Sorry. So the space here between the two cartilage is open, but this is still closed. Are you following? So when I speak, the two cords, the membranous part of the rhemagglottis is closed, but the intercartilaginous is open. When I don't speak, both of them are closed, are open, and I breathe. So I'm telling you something here. When we say hoarseness of voice, hoarseness is not whispering, because somebody in the mail, I said, what's hoarseness of voice? The patient will say to you, whispering. No, this is whispering. But hoarseness is like a horse. The patient will say, instead of whispering, he will say that.
No voice?
So he is no voice, but there is articulation. There is articulation without a voice. If you go to a stable, and I said it yesterday, I used to live with my uncle, and he used to have 2 or 3 horses. Horses together, they meet like this, and they do this in the stable. I said to him, yeah, they talk. I said, there is no sound. Yeah, they talk. This is hoarseness. So hoarseness is articulation without a sound. And when there is hoarseness, the two cords and the two, they are away from each other. But when there is whispering, the two cords are meeting each other, but not the cartilage. And when there is speaking like this, the cartilage and the membranes, the cord, they are meeting together. Are you following? Yes. يبقى فهمنا كلمة hoarseness of voice?
Yes.
Hoarseness, does it mean whispering?
No.
No. Here is the cord. Why does it appear whitish from up? Here is the arytenoid. Here is epiglottic fold. The superior edge of the superior edge of the quadrangular membrane. The same epiglottic. This is the epiglottis. This is here arytenoid. Why is it whitish? Why the cord is whitish? Why the fold is whitish? Because there is no blood vessels there. When I speak, there is mucosa. When I speak, the cords hit each other 1,000 times, like this. Imagine that if I have blood vessels here and they hit each other 1,000 times, what will happen to the blood vessels? And whenever I speak, I'll say, oh, blood, oh, this will be life? Impossible. Can there be blood vessels there? No. This is why they are whitish. But the folds are not whitish. Now, this is again in the notes of 2009. How to make nomenclature to anything in the larynx without a mistake. Look, beautiful. This is not conventional studying. A cricoid here, thyroid here, and this is epiglottis, this is posterior. The nomenclature always go from down up, like this. I will say cricothyroid, cricoarytenoid. I will say thyroepiglottic. And I will go only once here posterior, but this still going up, aryepiglottic. Can I say epiglottico? No. So I say aryepiglottic, thyroepiglottic, cricothyroid, cricoarytenoid, thyroarytenoid, and this is the direction I should put my mind while I'm making the nomenclature of any structure. And without a mistake. You cannot find it in any book. Here, there is thyroid, and here arytenoid. So this muscle is thyroarytenoid. Here is epiglottis, and this is here thyroid. So thyroepiglottic. Here is cricoid, here is arytenoid, cricoarytenoid. You see how beautiful it is? Here is muscle at the cricoid, and the thyroid was cut, cricothyroid. All of these, here we are. So this is cricoarytenoid. This is cricothyroid. Lateral versus posterior cricoarytenoid muscle again. Here is my arytenoid, and this is vocal process. This is muscular process. Muscular process, vocal process. Muscular process, muscular process, vocal process, vocal process. Here is the cord. Here is lateral cricoarytenoid. Here is posterior cricoarytenoid. This is adductor, this is abductor. If this contracts this way, I'll approximate the cord. If this contracts, you will see it here. If this contracts, here what will happen.
Nice. Very good.
This is McGill table. I'm simulating the function of the posterior cricoarytenoid. Here I'm simulating the function of cricothyroid. When I go anteriorly to make tense the chords to go with the high tone. Cricothyroid. What's the nerve to cricothyroid? What's the nerve to cricothyroid? The nerve to cricothyroid, I want you to remember this. Cricothyroid, if you look at it, it looks like a papillon. عارفين البابيون؟ Bow tie. Bow tie, we wear it in external affairs. عارفين البابيون؟ You know the papillon? Bow tie. أنا بكرهه ما بحبوش بيبقى عامل زي القطة في بيسيبها مسيحة. يعني والله يعني أنا بعتبره مش لبس حشمة. It is not anyway. But anyway, it is for external affairs, and it is supplied by external laryngeal. So external laryngeal nerve is supplying cricothyroid. And if external laryngeal nerve is affected, no. No monotonous voice. What's monotonous voice? The same tone. I would say, good morning, I like you, I hate you, the same. Are you following? The same tone. So monotonous voice is when the external, and this happens when we do thyroidectomy, while we are ligating the superior thyroid artery, while we are dissecting the superior pole of thyroid. But if I am dissecting the inferior pole of thyroid and or ligating the inferior thyroid artery, I might hit the recurrent laryngeal, and here hoarseness will happen. So hoarseness is down, while monotonous voice is up. Here are the chords when they hit each other. Here are, I can show you when they hit each other, but here we are looking, again, this is aryepiglottic fold, what's this? Arytenoid and this, epiglottis. What's this space? This space in the exam 100%. What's this space? We call it pyriform fossa. What do we call it? And it is in the pharynx, in the laryngopharynx, because here we are in the pharynx, in this space here we are in the pharynx. And in front of us is the larynx. Here, we are here, we open the pharynx. You see, we opened this part of the pharynx. When we opened it, we saw here the entrance of the larynx. We saw the cricoid from posterior view, the lamina, sitting on cricoid arytenoid, aryepiglottic fold, and these are here. This is pyriform fossa. What I'm seeing here is a fold of a linear structure. This linear structure is called internal laryngeal nerve, not external. And the internal laryngeal nerve is forming a fold because there is mucosa on it. And the internal laryngeal nerve is supplying the supraglottic part of the larynx, responsible for coughing. This is why the internal laryngeal is thick, very thick, quarter the thickness of sciatic. Imagine why to have a lot of spies in the mucosa, to know everything. So if any foreign body goes like this, coughing, immediately coughing. So it should have a lot of spies to know what's happening. Are you following? And it is piercing the thyroid membrane. It is piercing what? Thyroid membrane. And what we are seeing here, the posterior aspect of thyroid membrane, while it is piercing it. Here is quadrangular membrane, and here is thyroid membrane. This is why in 2009 I said the pyriform fossa is a space between two membranes. Laterally is thyroid membrane. Medially is quadrangular membrane. The space between two membranes. The importance of this is when 70-year-old guy comes to you complaining of some pain in the throat and dysphagia, difficulty in swallowing, and he is smoking 70 years, look first at the pyriform fossa. Very important, because if you catch the pyriform fossa cancer early, there is treatment. If not, you cannot. Pyriform fossa is drained by a very important lymph node here called jugulo-omohyoid. It is the second largest one. What's the first largest one? Jugulo-omohyoid lymph node. What's the first one? The first one is jugulo-digastric in the neck. The master lymph node in the neck is jugulo-digastric. The second one is jugulo-omohyoid. Both of them are present in the carotid triangle. So, if the jugulo-digastric is enlarged and the patient is 70 years old, smoker, having dysphagia, it's late. It is late. It is late. If he is 70 years old smoking and dysphagia, and you went and you saw the cancer in piriform fossa, but the jugulo-digastric, the jugulo-omohyoid is not enlarged, it's not late. How the cord hit, how one cord is hitting the other to make a sound. This how, yes. Okay, خلاص, yeah. Yes, this is here, please. I'm Mandishwar. This is jugulo digastric. This is jugulo-digastric, jugulo-omohyoid. This triangle is carotid triangle because there is carotid here. And you see here, whatever is happening is going here. If I have carcinoma here, it will go to jugulo-omohyoid. Also, if he is a smoker, now, if he is a smoker and he came to you, no dysphagia, 70-year-old, 50-year-old of smoking, and this is enlarged. But no dysphagia, I'll go also to this. What's this? Piriform. I didn't find anything. I'll go, you know where? Tip of the tongue. Because tip of the tongue and piriform fossa, both of them, tip of the tongue and piriform fossa, both of them go to jugulo-omohyoid, both of them. So 70-year-old smoker, no dysphagia. Jugulo-omohyoid enlarged, I should go to the tip of the tongue if the piriform fossa is not having cancer. Here is internal laryngeal, supplying supraglottic area. What supplies the infraglottic area for pain and temperature and reflex? Recurrent. The sensory nerve supply for infraglottic area is recurrent. For supraglottic area, internal. The papillon is supplied by external laryngeal. The rest of the muscles here are supplied by recurrent laryngeal. If I have, this is supraglottic, infraglottic. If I have injury during surgery, if I have injury of this external, I have hoarseness, monotonous. If I have injury here, I have hoarse voice. Hoarse voice doesn't mean whispering at all. This is the pharynx, and the pharynx has got three muscles. We know already. Superior constrictor arising from PMI, middle constrictor from greater horn, and it is sharing with which muscle? The greater horn, hyoglossus, and this muscle inferior is sharing the oblique line with two muscles, the thyrohyoid and the sternothyroid. And these muscles are arching from both sides, one arch from one side, one arch, and they meet together at like a Japanese fan. They meet together at what we call pharyngeal raphe, and this is the pharyngeal raphe in the middle. And they telescope into each other like cups. And the first layer here is the membrane. This is why this is membranomuscular structure, and the membrane here, which is completing the wall here, is called pharyngobasilar fascia, and jumping on it, the telescoped cups, and this is the pharyngeal raphe. The same idea, but we have here all what we know, the PMR, the the hyoglossus, and this is the middle constrictor, and this inferior constrictor divided into two: thyropharyngeus and cricopharyngeus. All the muscle above are Japanese fan, but the cricopharyngeus is a sling. A sling means that it forms here what we call a sphincter. This sphincter is 24 hours under high tone, closing the lower part of the esophagus, the lower part of pharynx and upper part of esophagus, opening only during deglutition. Exactly remind me of the other end of the GIT, which also closed for 24 hours by puborectalis. Here we are. Look at this. This is here, middle constrictor, the inferior constrictor, the thyropharyngeal part. This is thyrohyoid. This is thyroid here. This is sternothyroid. This is the origin of the inferior constrictor, the thyropharyngeal part, and the cricopharyngeus part. This is Japanese fan, but this is the sling. If I have incoordination during swallowing, if I'm swallowing and it is closed, I will have a pouch. This pouch is called Zinker pouch. This muscle is reminding me of puborectalis. Here is the whole pharynx, and I have nasopharynx, oropharynx, and the laryngopharynx. Behind the pharynx, I have a space called retropharyngeal space with fat in it and lymph nodes. The fat will lubricate the movement. Here I have the key organ or the key structure in the whole neck, which is the hyoid bone. At the level of C3, base of skull, please. Here this part is nasopharynx and oropharynx, and this part is the laryngopharynx. 3 vertebrae. Soft palate is separated, please, and please. Soft palate, when it is stretched and elevated, it will separate the nasopharynx from the oropharynx. The most important feature in the nasopharynx is this tube called called Eustachian tube. Eustachian tube in the baby, 5 minutes, okay? Eustachian tube in the baby will be in the oropharynx. Eustachian tube in the baby will be in the oropharynx until the age of 1 year. If this is my baby, please listen to this, more important than anything. If this is my baby and I'm actually feeding it, I should not put it like this, and put the milk, because the milk will go directly to Eustachian tube to the middle ear. So it should be propped up like this. Even in the British television, they tell you, please breastfeed or feed your baby propped up, because the Eustachian tube is in the oropharynx. After the age of 1 year, it goes in the nasopharynx. Otherwise, when you breastfeed it like this or feed it like this, it goes directly to the middle ear, and the middle ear will be infected and he will lose his hearing. Here also we have what? Here also we have what? Adenoid. And adenoid, if it enlarge, it will block here. It will block here and block what as well? And it will block the guana. And the toddler will snore while sleeping, and then the oxygen will go down. This will make pulmonary hypertension, and the right heart will fail. If you do the operation, the right heart will come back and the pressure will go down. Also, when it enlarges, this adenoid, we call it pharyngeal tonsil. When it enlarges, as I said, it will block the tube, and the middle ear will be closed, and he might lose his hearing. This is the most important thing we have to know about the. Then, now we know the nasopharynx very well. Let's go to the oropharynx to see what's important. In the oropharynx, the most important thing here is my tonsil, between the second and the third fold. And the tonsils, you know, and I want you to know also that the posterior third of the tongue is in the oropharynx, not in the oropharynx, not in the oral cavity. Here is the tonsils. Let me have the tonsils very fast. Let me have the tonsils. Here we know what's more important for us to know here is this space. You know this space very well. The piriform fossa between the two membranes. Let me go to the tonsils very fast. I want the tonsil. Here is the tonsil. When it is enlarged and diseased, it will affect the heart. You agree? Yes, it will affect the heart. This is a cleft where if I eat fish, the bones will stick here. The heart is affected. But tonsillectomy, please look at this. Tonsillectomy causing the patient to die. Why causing the patient to die, tonsillectomy? I want you to know something. This is the last in my lecture. The tonsil is supplied by what? External or internal carotid? External. Through which artery? Facial. Facial coming from where? Maxillary. And facial will give something called tonsillar. It will go to the bed of the tonsil. If I remove the tonsil now and it is oozing a bit in the bed, this means what? This means that, please, this means that the tonsillar which is coming from the facial is oozing. But if I have torrential bleeding, is it then tonsillar? It is internal carotid. Why? Apparent internal carotid. It is what? Apparent internal carotid. Watch this with me. This is the last of my lecture. Look here. Can you look at this? This I used to make it when I was young. I like this. Okay? So this is tonsillar coming from facial. You can see tonsillar coming from out of facial. And I can embolize it if I want, if the bleeding is small. But this is apparent internal carotid. Compare this to this. Compare this to this. And here is the tonsil between the two pillars. And this is here is inflamed for a year. And it caused this to slough after the operation. And if it is sloughing after the operation, I have torrential bleeding and the patient will die. It happened twice when I was in Canada. Like this, from apparent internal carotid. And this what we spoke earlier about. And last but not least, I want you to remember always the dangerous space, which is here. It can take me down into the dangerous space. Space is behind the alar fascia. If I have an infection here, it will go down to the heart. It will go down around the heart in the mediastinum, the danger space. There is another thing. This is retromandibular. This is jugular-digastric and interna-jugular, and these are retropharyngeal nodes. When they become enlarged, they can push and make me not breathe nicely, and this happens because of tonsillitis. Anyway, what's left is not that very much. It is a small piece. Hopefully you enjoyed this and you understand something and you learn something. Thank you very much for listening.
Thank you very much.